Hello everyone. Today I'm going to talk about the flow volume loop. In my previous teaching, I spoke about the expiratory flow volume curve. And if you remember the diagram from the previous teaching, which is this one here, so that only has the expiratory limb. So again, just to repeat it on the x-axis and the y-axis. So you can see the force expiratory flow and the peak expiratory flow here, and then you have the linear curve which is there as the lung volume reduces. So this is known as the effort independent, and this is the effort dependent. So what is the difference between the two? Now, in this, you will see that the loop is completed when there is expiratory curve, and at the same time you have the inspiratory flow curve, so which will give us the completion of the cycle that is known as the flow volume loop. Now remember, we are studying the spirometry, and this is the part of the pulmonary function test. So in this, patient is asked to take a deep breath in and exhale in the spirometer. So that's how you get the expiratory flow volume curve. If you look at this picture here, so that's the expiratory flow curve. And in this figure here, you can see the expiratory flow curve, and at the same time you see the inspiratory limb here. So it starts from the total lung capacity, where you're going to start the expiration towards the residual volume, and then your inspiration begins from the residual volume back to the total lung capacity. Now our tidal volume is about 500 mils. So that lies in between this here. You can see this. Now, what is the significance of this loop? This can actually provide us the additional information in diagnosing the respiratory problem, especially when there is uncertainty about the obstruction in the airway, where actually the obstruction is. Sometimes a patient may present to you with a wheeze, but the history could be inconsistent with asthma or airway obstructive disease or COPD. Now, as I said that this is the diagnostic tool for differentiating between the airway obstructive disease. So if you look at this picture here, what it shows is that if a person is suffering from fixed obstruction, the example for that could be tracheal stenosis or a foreign body. So in this case, what happens? The lung volumes remain unchanged, and also the narrowing is not changed throughout the respiratory cycle. So whether it is inspiration or expiration, the obstruction is fixed. And the example is the tracheal stenosis of the foreign body. So in that case, what happens? Both expiratory and the inspiratory peak flow will be reduced, and you will see the flattening of the curve during expiration and inspiration, because it's the fixed narrowing. That's why the PEFR is reduced and the curve is reduced in both parts of the cycle. No matter how much respiratory effort is made, it cannot overcome the obstruction. Now, this is the example of variable extrathoracic airway obstruction. Now here we have two words. Number one is the extrathoracic. That means the airway obstruction is above the level of sixth tracheal ring, and variable means that the obstruction is freely movable during the respiratory cycle. So what happens in this case? When a patient breathes in, so the subatmospheric pressure will pull the trachea or tracheal lesion downwards, and that is going to cause the obstruction in the flow, and for that reason you will see the flattening of the curve in the inspiratory curve. But as the patient breathes out, the positive pressure is going to push the obstruction outwards, and there will not be any obstruction to the flow, and for that reason you will not see the flattening of the curve in this part. In our clinical practice, you might have seen the patient suffering from laryngospasm soon after extubation, where they have great difficulty during inspiration, but expiration they do not have the airway obstruction. So, in those patients, you will hear a sound which is called a stridor, and that will give the flattening of the curve during the inspiratory curve. This is the example of variable intrathoracic airway obstruction. So what happens in this case is, number one, intrathoracic means the obstruction below the level of sixth tracheal ring, and once they become the intrathoracic, for example the tumor, if it is intrathoracic, it is subjected to the intrathoracic pressure. So what happens in this case, when the patient inspires or takes a breath in, it produces the negative intrapleural pressure. So with that negative intrapleural pressure, the lung parenchyma is stretched. So when the lung parenchyma is stretched, the airways, as I had previously explained, then the diameter of the airways increases. And as per Hagen-Poiseuille's equation, when the diameter of the airway or any tube increases, the pressure will be reduced. So when the pressure is reduced, the flow will increase, and for that reason you will not see any flattening of the curve during the inspiratory limb of the flow volume loop. But when the patient expires, then what happens? The negative pressure changes into the positive pressure, and as I had already explained that when the lung volume reduces, it puts pressure on the small airways and the airways will collapse. So that was known as the dynamic airway pressure. But if there is a tumor, it's going to further cause the obstruction of the airways, and that is going to cause the flattening of the expiratory curve, which you can see here. So I hope it is easy to understand that if there is a fixed obstruction such as tracheal stenosis, you will see the flattening of the expiratory limb and the inspiratory limb. But if there is extrathoracic obstruction, you're going to see the flattening of the inspiratory limb, and if there is any intrathoracic obstruction, you're going to see the flattening of the expiratory curve of the respiratory cycle. Hopefully I have made it easy to understand for you, and keep watching my YouTube channel for more videos. Thanks.